Hi everyone. So this discussion today is on the basis of a poll, an opinion that I had taken on the group, which suggested that I should be doing a bit of an overview or a summarization of the session that we had. I also believe that this is the first time that I'm showing my face onto this group, onto this channel. So I decided that the discussion that we had the other day, hyperglycemia in pregnancy, it was a case that was presented by Dr. Kuniga. It was presented really well, but I did believe that due to a few technical glitches and a few technical shortcomings, we weren't able to do enough justice to that session. So I decided that today, and also that session went on for almost 2 hours. So I decided that I would want to summarize the entire topic and base this discussion today on the same topic but in a much shorter span. Now, what I intend to do is I'm not going to be discussing the entire topic. I'm just going to be talking about this topic in terms of how is it relevant and what are the questions that you can expect in your practical exams. Now, remember that hyperglycemia in pregnancy, or what you might as well call gestational diabetes mellitus, is one of the commonest disorders that you find in your antenatal ward. The reason being, a lot of these women are admitted for insulin titration and for sugar monitoring to optimize their sugar levels. So you stand a very high chance of getting this case in your exam. This preeclampsia, fetal growth restriction, anemia, all these are the more common things that you find in your ward. The lesser common ones being antepartum hemorrhage or something like heart disease in pregnancy. All these things you wouldn't find them that commonly in comparison to this topic. So I believe that this topic is very important, and our discussion is going to help you all to make or to get through this topic in great sense. So let us begin with the session. So first of all, before beginning on how do you present this case, the first thing is you need to know about the terminologies. So until now, until my batch, I was someone who gave my final year MBBS exams in 2019. So at that point of time, though there was an update that was issued by FIGO in 2016, I was not aware of it. So what we followed until then was two terminologies. One was overt diabetes mellitus, and the other one was gestational diabetes mellitus. Overt, as the name suggests, is something that a female has prior to pregnancy. So diabetes that is there with her from the preconceptional period. So the onset of diabetes, I'll mention this column as onset of diabetes, is prior to pregnancy, where a GDM is classically from the late second trimester. So basically during second half of pregnancy. The other name for overt diabetes mellitus was also pre-gestational diabetes mellitus. So these are the two common names that we used, but now there were a few shortcomings for this classification. What were those shortcomings? So the basic shortcomings were that we never knew, or we didn't get to know on what is the cause or what is the reasoning behind these women getting overt diabetes mellitus. So was it type 1 or type 2? There was no category or there was no classification of the same. Now what is type 1? As we all know, type 1 is basically nothing but diabetes that is occurring because of lack of insulin or deficiency of insulin. It might be because of some pancreatic disorder, or it might be because of some infection to the pancreas or pancreatitis, or it can be type 2 wherein there is insulin but there is resistance to that insulin. So there is resistance to all the insulin receptors. So the new classification which was given by FIGO in 2016 was hyperglycemia in pregnancy as the broader umbrella. Under that they gave two classifications. What were those two classifications? Those two classifications were diabetes in pregnancy and gestational diabetes mellitus. Now, very easy to remember. Over here you can see that diabetes is occurring before pregnancy. In the word itself, in the nomenclature itself, diabetes is seen prior to pregnancy. So it indicates that the female has diabetes prior to conception. It also indicates that diabetes that develops in the first trimester. Diabetes diagnosed for the first time during first trimester. So either of these two. Whereas GDM is classically gestational diabetes mellitus, wherein it is occurring mostly in the second half of pregnancy, and it is basically G, that is gestation is coming before diabetes. So as the name suggests, that G, that pregnancy is occurring first and then diabetes is coming into the picture. So the names are good enough to give you an idea that what might be the origin of this. So diabetes developing during pregnancy. Then they said that to know what is the cause of that diabetes, we'll categorize them as type 1 and type 2 for both of them. So both can have type 1 and type 2 under them. So this was a very simple classification that they have given. Now the thing is, just like during my final year exams, I myself wasn't aware of this classification that had come in 2016, but currently there are a lot more people, a lot more of your examiners who would know this classification. Though most of them would know, a few still wouldn't know. So it is prudent that at your end you know both the classifications, this as well as the earlier one. So that is it about the nomenclature and how you would be progressing with your nomenclature, with your use of words. So now beginning with the case. The first line when you are taking any case or the first part of your history, there are few parts to the history. So the first one, the way we follow as postgraduate students, there's a certain format that I follow at our level, and I do believe that that is a format that you can follow at your level as well. It is very much correct. There is no one who will object to you. So in that, the first part is the demographic history. So I ask about the demographics. And by demographics, I intend to say all the things like age. Obviously, gender is not important here because it is going to be a female. So age, occupation, educational status, and residence. Though the residence is not going to make a big difference, but I will tell you at a later point how does residence play a role. I'm just giving you a brief introduction. How would you mention it? Then the next point is going to be duration of your current pregnancy. That will constitute LMP and EDD by Negley's formula, and the gestational age that you would calculate. I would want to take a separate lecture on the live session, and I'm going to teach you how to take gestational age or how to calculate the gestational age in a very easy manner. I'll give you an example today as well, but a lot more detailed discussion on the same in one of the subsequent live case discussions. The next part is going to be complaints. So what you call as HOPI, I would just call it current complaints. In current complaints, I have two categories. One are the general complaints that any pregnant female will have. She need not be having diabetes or preeclampsia or anemia. Those are general complaints. Whereas the next one are specific complaints. By specific, I intend to say specific to the comorbidity that she has, specific to the diagnosis that this patient has. In this case, it is going to be diabetes mellitus. After that, you would be asking her past history. In the past history, you have again two segments: medical history, which includes all those 6-7 symptoms of history of diabetes mellitus or history of hypertension, thyroid disorders and tuberculosis, epilepsy, all those things. Whereas the next one is going to be surgical history, if she has had any surgery that was done on her in the past. Next comes family history. So in family history, you would just ask if she has any history of metabolic syndrome in her parents. And lastly, drug history. Now, drug history is something that you can even put a little earlier. It depends on you. I prefer to put drug history even after the current complaint. So, in drug history, in this patient, it is going to be if she's consuming oral hypoglycemic agents, or she's consuming, or she's taking injections of insulin. So, drug history is going to be everything about that. Next is going to be your obstetric history. When I talk of the obstetric history, I would first want to mention about her previous pregnancy. Also, one more thing, in this duration of pregnancy, you can also, and you have to also mention her parity score. So, in obstetric history, I'm going to mention each of her pregnancies chronologically, and I'm going to be describing them in short. And then finally, I'll be coming to the current pregnancy. Assuming that she is gravida 4 in current pregnancy, I'll talk about that. Once I'm done with my obstetric history, a lot of people tend to talk about menstrual history. I do not believe that menstrual history is that significant in these patients, because it really doesn't carry much significance. You can mention it, but you can as well skip it, because I don't believe it adds any value to your history. You need to be crisp, you need to be precise with your history. Your menstrual history is not going to make any difference in that. The only difference that it might make is if your examination findings, the per abdominal findings of symphysiofundal height and the size of the baby is not matching, is not corresponding with your gestational age that you have calculated. In that scenario, if she says that she has been having irregular menses because of PCOS or something, PCOS this female might have because she now has diabetes. So only in that scenario your menstrual history might carry some value, but you can as well skip it. The next is going to be diet history. Diet history is something that I find very annoying. I don't really focus much on that. And next is going to be your examination. In examination as well, just like all other subjects, you have two major points. Those two major points are, first is general examination, wherein you mention all the vitals, if she's febrile, if she's having high temperature, how's the general condition, and all other general systems. Whereas in specific systemic examination, it will be a small line on cardiovascular respiratory system, but a significant mention to our systems, that is per abdominal, per speculum and per vaginal examination. Now at your level, in most of the colleges, you all are not allowed to do per speculum and per vaginal examinations. At postgraduate level, we are allowed to do it. So per abdominal examination carries all the significance when you are talking about systemic examination, whereas per speculum and per vaginal, you can just mention that it was not performed. So finally, you would be summarizing your history at the end of it. Summarizing with provisional diagnosis. So provisional diagnosis, there is a way how you mention it, but I'll be mentioning it at the end of it. Why do I say that this is a provisional diagnosis? Because at that moment I do not have investigations that I have available at my hands. I do not know whether what were her values earlier. I have no idea about her earlier symptoms, earlier blood tests or her imaging studies. So I cannot arrive at a definitive diagnosis, which is why I will be only giving a provisional diagnosis on the basis of my history and examination. A few people prefer to give their provisional diagnosis after history, though I do believe that examination gives you a lot more points to be affirmative or to be assured about your diagnosis. So I prefer to give it at the end of examination. Then coming back, starting from the first part of history. The first part of history that we had mentioned, this is, by the way, your general skeleton, what I would say, skeleton of history taking for this patient, and this skeleton is going to be valid for all patients, just that a few things will come and go, but this skeleton can be used for every patient irrespective of the diagnosis in obstetrics and gynecology. So now coming to the specific parts of it. The first part that we mentioned was the demographic history. So in demographics, in this female, now that I know that she is a case of diabetes, in demographics, the most important part is going to be, or the most important point is going to be her age. Now, in women who are elderly, and by elderly I intend to say mostly more than 35 years of age, we have a lot more chances of having diabetes mellitus, especially overt diabetes mellitus. For the sake of the discussion, I am going to be using the terms overt diabetes mellitus and gestational diabetes mellitus. Excuse the cough. Overt diabetes mellitus is now known as diabetes in pregnancy, as I've mentioned earlier, by the FIGO's new classification. But overt diabetes mellitus for the sake of this discussion, and so that you all understand, you all are comfortable with some terminology, and that has been ODM or overt diabetes mellitus, which is why I'm going to be using that. So in demographics, the most important part is going to be her age. I mentioned that residence has something to do with diabetes mellitus. What is it? It's a very indirect correlation. Now, people who stay in a lower socioeconomic strata, in conditions where they don't have optimum resources, there is one problem that these women face. Insulin, if they are taking, insulin is a drug that needs to be refrigerated. They need to keep it in a refrigerator, and if they are keeping it outside, if they are keeping it at room temperature, it can be anything anywhere in Mumbai. In Mumbai, it is somewhere between 30 degrees regularly, or even higher, even up to 35 degrees during summers. That insulin loses its potency and efficacy both. In that scenario, the insulin that she might be taking is nothing but just plain saline जैसे ही होगा वो. It is like, it is not going to be as effective as it should be, and she is never going to achieve optimum sugar levels, which is why residence plays a factor in here. We often forget to ask. We just start the female on insulin. We admit the female in the ward, we start her on insulin, we teach her how to take it, her sugar levels get maintained, we discharge her, she comes back to me after a couple of weeks and she shows me that all her sugars are again deranged. And she mentions that I've been taking the dose in the same way as you had taught me, in the same way I'm measuring it as well, but yet the control is not being achieved. Then you have to ask her, how do you store your insulin? And often these women tell you that, sir, I've been keeping it near my bed every day, and I take it just alongside my metformin or my other folic acid, all those tablets. That is where you have to understand that your residence plays a very significant role. Hence, a lot of women, once you're telling them how to take that insulin, also tell them how to store it. So they often tend to store it in their neighbor's home who have a refrigerator available, or you can advise them to go to a local practitioner who will have a refrigerator set of his own, and he or she can store it in their refrigerator. So yes, residence plays a role on that sense. Occupation, yes, to certain extent it will have some bearing on your diagnosis. Remember that occupation, especially the occupations which require to stay up in the night, so night jobs or night duties, basically jobs that require to be awake, that can disturb or that can give you an imbalance of your sympathetic nervous system. So whenever sympathetic nervous system increases, or there is an overdrive of sympathetic nervous system, there is going to be hyperglycemia. So hyperglycemia or uncontrolled sugars, metabolic syndrome, people tend to eat a lot when they are doing a night shift just to help them stay awake. They tend to consume a lot more of caffeine through coffee. All these things, although I might tell that it is more so in the middle and upper economic strata, but yes, very significant. You have to ask them what their occupation is, if they are getting adequate sleep that the pregnancy requires. All these things can play a role in the control of sugar in this patient. Once I'm done with the demographics, I come to the next part of it, wherein I'm going to be asking her about her duration of pregnancy. Duration and parity score. So assuming she tells me that, let us just assume that she says that this is my second pregnancy and my first pregnancy was a cesarean section. So I will say that she is gravida 2, para 1, living 1 with previous LACS. Now there was a question that someone had asked me during the session on PNC case. The question that was asked to me was, sir, now that she is delivered, because she was pregnant, shouldn't it add to the gravid status? No, once you deliver, G disappears from the parity score. G is indicative of current pregnancy state. The second you deliver that female, she is no longer a gravid, she is just paris. So remember that gravida 2 is only until gravida 1, yeah, gravida 2, gravida 3, whatever, is only until she is pregnant, until she has that baby inside her. So she says that I am gravida 2, para 1, living 1 with previous LACS. This is my parity score. I ask her what her LMP was. So let us assume she tells me that her LMP was just a random number I get on my mind, 2nd of February 2024. So by Negli's formula, I'll be saying that I have to add 7 to this. So if I add 7 to this number, then it becomes 9 over here. Then I have to add 9 months to the month, which becomes 11, that is November 24. There is one factor that you need to know, that this year is a leap year, so leap year has an extra day in February. So this ideally will reduce 1 from here, so it will become 8th of November 24. But that is fine. If you forget this month, it's okay, but at least roughly this should be your expected delivery date by Negley's formula, wherein you add 7 to the date, to the day, and 9 to the months. The other way of doing it is you subtract 3 from the months column. So if I'm going to be subtracting 3, then it will again come out to be 11. Fine. Now how do I calculate the gestational age? A very significant, a very important point over here. There are two ways in which I can go about it. Remember a basic concept. My pregnancy starts at 0 weeks and it goes up to 40 complete weeks of gestation. Agreed? So this pregnancy is of 40 into 7, that is 280 days. So it goes up to 40 complete weeks. So I have two ways. Either I can measure from 2nd of February to the 8th of November and know what is the gestational age, or I can go reverse. I can come back from this date to this date and calculate what is the difference. Now what do I intend to say here? Now what is today's date? Today's date is 3rd of October. So आज का डेट है 3rd of October 24. So now I have two ways. I can either come from this and then find what is the gestational age, or I can come from this, go backwards and then subtract this period from 40, because at this point she completes 40 weeks. She is 0 at this point and she completes 40 weeks at this point. So I can either subtract from 40 what is remaining, or I can add from 0 and reach here. Now that I'm more closer from this route over here, then I'm closer from this point of 0 till today, then I will go with the subtraction method. So how do I subtract? So today is the 3rd of October. So in 3rd of October, I still have 28 days that are left in this month. To add to it the 8 days of next month. So it amounts to 36. Now what is 36 in terms of weeks and days? It is 5 weeks and 1 day. Now if I subtract from 45 weeks and 1 day, it will become 34 weeks and 6 days. And that is how much our pregnancy is at the moment. 34 weeks, 6 days. Now at your undergraduation level, if you are able to answer this question, if you are able to answer the gestational age in exact weeks and days, it is going to put an immense amount of impression on your examiner, because this is something that only postgraduates do. So if you are able to do this, amazing. There is nothing like that. Just to give you another example, today's date again 3rd of October 24, and assume the female tells me that her LMP was let's say something like 4th of August 24. So her EDD is going to be, I am going to add 7, so 11. Now I am going to add 9. So if I am going to add 9, it can go into a number like 17. I don't know what is the 17th month, so I can subtract 3 from it. So if I subtract 3 from it, it is going to be 5. So the year has changed and it is going to be 2025. Now again, to come to 3rd of October from this point, that is from point 0, is going to be much easier now, instead of coming back from 40th week. So what I do is, इसके आगे कितने दिन हुए हैं is what I will calculate. So कितने दिन हुए हैं? August had 31 days. 4 दिन मुझे गिनने नहीं है, so 4th के बाद से गिनना है. So it is going to be 27 days of August, 30 days of September and 3 days of October. So this amounts to 60. What is 60 in terms of weeks and days? It is going to be 8 weeks and 4 days. Hence this pregnancy is going to be of 8 weeks and 4 days. So I've taught you both the methods, how to come from behind and how to come starting se aage. Fine. It is okay if you all don't know this, if you all can roughly calculate and you can say the female is from 35 to 34 weeks of gestation, that is good enough. But if you are able to do this, nothing like that. Great. So once I'm done giving the parity score and the gestational age, I proceed. Now what is the significance of gestational age? Gestational age is going to tell me what kind of diabetes is she on. If it is recently diagnosed and if she's like 35 weeks, as was our case yesterday. So if she's at 35 weeks and she's just recently diagnosed, then I know that she's a case of gestational diabetes mellitus. But if she says, as was our case, that she had diabetes since the 4th month of her pregnancy, 4th month is somewhere around 16 weeks. So if she's having diabetes at 16 weeks and she had overt diabetes mellitus, but why have I admitted her right now? Because right now her sugars were not getting controlled, which required me to admit her. So the gestational age is going to give me an idea, rough idea on what type of diabetes is it. Obviously it is also going to help me chart out a plan for her. So now that she's at 35 weeks, I will tell her that given that you are on insulin currently, an insulin based pregnancy has to be terminated at 38 weeks. She asks me, then what if I was on metformin? Then you can tell her that if you were on metformin, then I would have terminated you between 39 and 40 weeks. Then she says, sir, what if I was not even on metformin, I was only on diet control, or what we call as medical nutrition therapy? Then you can tell her that well, then I would have delivered you at 40 weeks. So that is how we progress: 38, 39 and 40. 38 for insulin, 39 for metformin, and 40 for the ones who are only on dietary control. A few people tend to deliver women who are on OHAs, that is metformin, and are well controlled at 40 weeks. You can do that, that's fine, but it has to be after 39 weeks. Fine. So I come to the current complaints. So what are our current complaints? I mentioned that the first are going to be all the general complaints. General pregnancy related complaints, there are 4 of them. Always remember, these 4 complaints have to come in each of your history. The first one and the commonest complaint that female gives you is going to be abdominal pain. The next one is going to be leaking per vaginum. The next one is bleeding per vaginum. And the last one is going to be decreased or absent fetal movements. Okay, so these are our 2 things. Now, how do I correlate my case of diabetes with each one of these? Now, if I'm talking about abdominal pain, she's at 35 weeks right now. So at 35 weeks, why should she have abdominal pain? At 35 weeks, if she is having abdominal pain, it can be either false labor pain or it can be true labor pain. How do I differentiate between false and true labor pain? A very simple thing. False labor pain is not associated with cervical dilatation, whereas true labor pain is associated with cervical softening and cervical dilatation. Also, true labor pain, the contractions are going to keep on increasing with each passage of time, whereas in false labor pain they are going to be erratic and not something that is substantial. So it can either be false or true. But if it is true labor pain, false labor pain, Braxton Hicks, not significant, you just let it be, it will go on its own. But if it is true labor pain, then it tells us that she is in preterm labor. Now, why should a patient go in preterm labor? How is it significant in diabetics? So the first reason is that if she had polyhydramnios. So polyhydramnios led to over distension of a uterus, and over distension of the uterus was a signal for the uterus to just start delivering the baby once it has reached its limit. So polyhydramnios can be one. The other one is macrosomia. If the baby has, what is macrosomia? Macrosomia is more than 97th percentile of effective fetal weight. So basically at that gestation age, if it is more than 97 percentile, then you call it to be macrosomic. Similarly, what do you call as IUGR or fetal growth restriction if the effective fetal weight is less than 3rd centile? Great. Next, the next point is going to be if she is having any infection, so genital tract infection that has led to preterm labor. Great. The next point is going to be leaking per vaginum. What is and how is leaking per vaginum correlated with diabetes mellitus? Again, there are 2 points here. The first one is if she had polyhydramnios, that led to leaking per vaginum, or what I will call as preterm premature rupture of membranes, that is PPROM. Whereas the other point over here is going to be how did she have leaking per vaginum? Because of, again, genital tract infection. What did those infections do? Those infections led to the formation of cytokines. One of those cytokines was prostaglandin. That prostaglandin went into the uterus and started contractions. Also, that cytokines, all those infections weakened the amniotic membrane, and that amniotic membrane, the tensile strength broke away and the membranes ruptured. So genital tract infections a lot more common in women with diabetes mellitus. Bleeding per vaginum, how is it significant? In patients with polyhydramnios, if there is leaking per vaginum, it can lead to abruptio placentae. So that is how it can be correlated with diabetes mellitus. And lastly, absent fetal movements, very important point, probably the most important point after abdominal pain in patients with diabetes, if there is sudden fetal demise or sudden IUFD as we call it. Now a discussion on what is sudden IUFD. Why do we call it sudden? I mean, obviously a fetus is going to die. Once it dies, it is a sudden death. But what is so specific about the sudden IUFD that occurs in patients with diabetes? Now the meaning of sudden is that you cannot predict it. You do any test, be it non-stress test, you do a Doppler, or you just do intermittent heart auscultation that you do on every OPD visit, none of them are going to tell you or are going to be able to help you predict if this fetus is going to die or it is not going to die. In other conditions like fetal growth restriction because of preeclampsia, you have Doppler changes. There are few changes that you can see oligohydramnios, all these things, but in this female you will have absolutely nothing, and then suddenly a female just comes to you and says, I had come just a couple of days back to you to check my baby. You had shown me that the fetal heart sounds are there. Today I am not perceiving any movements. You do an ultrasound and you get to know that the fetus has died. Why does this happen? Why is there sudden IUFD? There are a few reasons to it. Now remember that you have always heard that your hemoglobin, be it the adult or fetal hemoglobin, it has a lot more affinity to everything except oxygen. So it loves everything but oxygen. Similarly, when there is a lot of glucose because of hyperglycemia that is present in the maternal and fetal blood, remember that glucose does cross the placenta, then you will have something that we call as HbA1c in adults. वैसे ही fetal में it will be HbF1c. Basically your fetal hemoglobin or your adult hemoglobin is binding to glucose. Now the work of hemoglobin was to carry around oxygen in the body. In the fetus, if it is not doing that work and instead it is carrying around glucose, it will lead to hypoxia to the fetal tissues, because instead of oxygen it is carrying around glucose, the fetal hemoglobin. To compensate for that hypoxia, what the fetal body does is it will start polycythemia. It will say that let me increase the number of RBCs that I have. But the moment there is an increase in the number of RBCs, it increases the viscosity of the blood. It increases the viscosity of the blood, and I don't know what's the spelling of viscosity. It increases the viscosity of the blood. Once the viscosity of the blood is increased, the heart will find it much more difficult to pump a thicker blood than it is possible for it to pump a thinner blood. It is like the heart is asked to pump Fevicol instead of water now. This leads to cardiac overload, and eventually cardiac overload will lead to congestive cardiac failure. So congestive heart failure. This congestive heart failure will lead to IUFD. Now all these changes, none of these are going to be diagnosed or detected on any of your imaging modalities or antenatal surveillance techniques, which is why there is going to be sudden IUFD. There is one more thing that can happen. At this point, whenever there is hypoxia, the body also says, let me start anaerobic respiration now. This anaerobic respiration leads to lactic acidosis, and lactic acid is very much toxic to the fetal tissues. So again, lactic acidosis will lead to IUFD. So these two are the major mechanisms which lead to sudden intrauterine fetal demise in a baby, in a fetus. And that is why very important, if a female is or a baby is coming to you with, or a mother is coming to you with absent or decreased fetal movements, you have to immediately evaluate her. If the fetal heart sounds are present, you have to still admit her for the next 24 hours. You have to do a 2-hourly fetal heart rate monitoring for her to ensure that the baby doesn't die. So that is the reason why there is sudden IUFD. Fine. Now that I have spoken about all the general complaints, I now come to the specific complaints. In specific complaints, I am also going to ask her about her current illness. So she tells me that yes sir, I have diabetes mellitus. So the first question is going to be, when was it diagnosed? She tells me that sir, let us assume that apna kal ka jaisa case tha, it was diagnosed at 4 months of gestation. MOG is months of gestation. So it was diagnosed around 15-16 weeks. Then I say okay. The next question is, how was it diagnosed? Now she tells you, सर मेरा कोई तो खून का जांच किया था जिसमें मुझे एक शक्कर का पानी पिलाया था और मुझे बोला था कि मेरा 2 घंटे बाद खून का जांच होगा. What is it? What is it that you do at 14 weeks? You might just say OGDT, but you don't do OGDT at 14, 15 weeks, at 4 months of gestation. You do OGDT between 24 to 28 weeks or between 32 to 36 weeks. If it is being done at 14 weeks, then you need to know that it was something else, and that something else is Diabetes in Pregnancy Study of India, DIPSI test. Now, what is a DIPSI test? DIPSI test, first line of your answer has to be, it's a screening test, sir. It's not a definitive diagnostic test. Screening test, once it comes to be positive, then I go ahead and I do a diagnostic test called as OGDT. But before that, I have to do a screening test. Why is it a screening test? Why has it gained prominence? Then the answer is, it has a few advantages. The first is, no fasting state is required. So a female in our setup with lower socioeconomic strata women come from long distances. They come to my OPD, there's a long line, there are 100 patients to be seen. So they have to wait in the line for 3-4 hours. They have already traveled for 3-4 hours. So it has taken like 8 hours almost to reach here, and she has not even gone to eat because she worries that her turn might go away, the OPD might shut down. So उसको भूखे आने की ज़रूरत नहीं है. I will tell her कि तू भूखे आ जा तेरे टेस्ट के लिए, not advisable. You can tell her you can carry food with you, you just have to come and meet me. So no fasting state is required. Secondly, which also tells her that a fasting, that is FBS, PLBS is not required for her. ऐसा fasting blood sugar का कोई significance नहीं है. Secondly, if you have seen your parents or your grandparents do a blood glucose testing, they always collect the blood in a grey bulb, and that grey bulb is sent to the lab, and you get those reports in 6 to 12 hours. A few labs even take 24 hours. But basically the thing is, it takes a high profile, a very sophisticated machine to do that test. The advantage of this test is that you don't need any such machine, and all you need is a glucometer. वो वन टच का या ग्लूको स्पार्क ये सब जो आते हैं, so सिर्फ वो जो नॉर्मल पिन प्रिक वाला रहता है ग्लूकोमीटर, that is adequate enough. And the third point is that it is relevant, and it gives me a diagnosis of not just GDM but also overt diabetes mellitus, and also gives me the chance to know if she has impaired glucose tolerance. So what do I do in this test? The first thing that I do is I just ask a female to come to me on her first antenatal visit. By the way, we do this for all women. You might just say, yesterday Dr. Konika answered that you do it only in high risk population. Remember that all Indians are high risk for metabolic syndrome. So you do this test in all women. So at first antenatal visit, you do this test. How do you do it? You give that female 75 gram of anhydrous glucose. Remember, anhydrous glucose. Don't give ग्लूकॉन डी. बहुत सारे सेंटर ग्लूकॉन डी देते हैं. अरे ग्लूकॉन डी का काम ये टेस्ट है ही नहीं. ग्लूकॉन डी इज मेड so that whenever you are hypoglycemic because you have run something or you have just not eaten something for several hours and you need urgent replenishment of your body resources, of your body electrolytes, of your body glucose, that is when you have to consume glucon D. And to make it palatable, to make it sweet, it contains sucrose, shakkar, literally sugar hota hai usme. Sucrose is going to be, it's a combination, so it leads to an increase, it leads to a massive spike in your blood sugar level. So it is going to give you a falsely positive, a very high value. You have to use anhydrous glucose. It literally tastes like wheat ka flour jo hota hai, and it is not really palatable. So you have to mix it in 250 to 300 ml of water. So basically one average glass of water. Now the problem is, I just mentioned that this is non-palatable. I mean, it has a very poor taste. So what might happen is, especially at 14-15 weeks, when these women already have nausea and vomiting of pregnancy, hyperemesis gravidarum, they have a very low threshold. कुछ भी खाते तो उल्टी करेंगे. So there are two scenarios. She either vomits within half an hour of consuming it, or she vomits after half an hour. If she vomits within 30 minutes, then you call her next day to do the test again. You end the test basically. You tell her कि आज नहीं हो सकता, आप कल आ जाओ. So test cannot be done. But if she vomits after 30 minutes, then you can be assured that ठीक है, the test can continue. So after 30 minutes, if she has vomited, or if she has not vomited at all, or no vomit, then you tell her that after 2 hours you have to come to me, and after 2 hours I'll be doing your blood sugar levels, HGT जिसको बोलते हैं. Now we have three interpretations. Less than 120 is your normal value. You can tell her that safely, मैडम जी आपको अभी कुछ नहीं करना है, आप अभी डायरेक्टली जाओगे. अभी आप क्या करोगे, आप डायरेक्टली जाओगे 24 वीक्स पे, 24 to 28 वीक्स पे आप जाके करोगे OGDT. Whereas if this female has a value of more than 140, then you tell her, मैडम आपको जेस्टेशनल डायबिटीज़ मेलाइटस है, आपको कंफर्म करने के लिए इमीडिएटली अगले दिन ओजीडीटी करना है. यू हैव टू डू इट द नेक्स्ट मॉर्निंग बिकॉज उसमें एफबीएस भी लगता है आपको. द वैल्यू बिटवीन दिस, दैट इज बिटवीन 120 to 139, इज इम्पेयर्ड ग्लूकोज टॉलरेंस. इम्पेयर्ड ग्लूकोज टॉलरेंस का मतलब है कि यू हैव अ हायर रिस्क of developing GDM at a later point in this pregnancy and polyhydramnios. ये दोनों के रिस्क आपके बढ़े हुए हैं. तो सिमिलरली आप भी 24 वीक्स पे जाके ओजीडीटी करोगे डेफिनेटली. नाउ द प्रॉब्लम इज दिस फीमेल सेज, सर मैं ट्रैवल इतना करके आई हूँ, आई कैन नॉट डू एन ओजीडीटी. मेरे इधर होगा नहीं, यहाँ पे वापस आना इज वेरी कम्बरसम फॉर मी. सो व्हाट डू आई टेल हर? फाइन, Dipsika test is good enough for me to start you on a drug. So I will see if her value is between 140 to 199, then I will give her the diagnosis of GDM. And if the value is more than 200, then I will tell her that you have overt diabetes mellitus. Based on that, if she has GDM, if her values are between this, I have two options. I either start her on medical nutrition therapy or I start her on OHAs. Whereas if she has over diabetes mellitus, though I can start her on metformin, but the best drug is going to be insulin for her, because only that way is her sugar going to be brought under control. Now you will ask me MNT क्या होता है. We are going to a little into the management part. Medical nutrition therapy बोलता है कि आप 3 मेजर मील्स खाओ दिन में और 3 माइनर मील्स खाओ आप दिन में. 3 बड़े मील्स, 3 छोटे मील्स. 3 मेजर मील्स कौन से होते हैं? ब्रेकफास्ट होता है, एक लंच होता है और एक डिनर होता है. 3 माइनर मील्स इसके बीच में कभी भी खाया करो, छोटा मोटा खाया करो. ये मील्स में यू हैव टू एंश्योर दैट अराउंड 50% आर योर कार्ब्स, around 30% are your fats, and around 20% are your proteins. Once you have done starting this, remember, no trans fats, maida, biscuit, pastries, cakes, nothing, no trans fats at all. They're indigestible. Once you're done with this, come back after 2 weeks to me. Once you started the American nutrition therapy, come back to me after 2 weeks and do a post lunch or post prandial, a better term is post prandial blood sugar levels. Don't do fasting, just do a post prandial sugar level. You can as well do a fasting one, but only PPBS also suffices. If the level is less than 120, then you continue on MNT. If it is more than 120, अभी यहाँ पे वो कुछ ग्लूकोज टॉलरेंस का वो अपना और इम्पेयर्ड ग्लूकोज टॉलरेंस वो सब नहीं होता है. इफ इट इज मोर देन 120, देन यू स्टार्ट दिस फीमेल ऑन OHAs. Similarly, once she started on OHAs, I will call her back after 2 weeks. I will again do her PPBS. वहाँ पे अगर फिर से मोर देन 120 आया, then I will start her on insulin. Once insulin is started, तब 2 हफ्ता नहीं रुकना है. 2 weeks is a lot. तभी every third day, so every 72 hours you will admit her or you will ask her to do at home. You will do her proper fasting and postprandial blood sugar levels. Ideally, you have learned in medicine that you have to do 7 blood glucose monitorings. I do agree with that. 7 blood glucose monitorings क्या होता है? लंच ब्रेकफास्ट के पहले, ब्रेकफास्ट के बाद में, लंच के पहले, लंच के बाद, डिनर के पहले, डिनर के बाद. एंड 7th वन इज द नाइट का 2 to 3 AM के बीच में एक सैंपल लोगे. वो Dawn phenomena, Somogi phenomena, you have learnt in medicine. You have to check for it. Dawn phenomena is basically your nocturnal, that is 3 AM का blood glucose levels are high and they continue being high in the fasting stage. What is the treatment for it? You increase night का long acting insulin. What is Somogi phenomena? Because रात का इंसुलिन बहुत ज़्यादा हो गया है, 3 बजे हाइपोग्लाइसेमिया हो गया, the blood sugar levels were very low, and as a compensatory mechanism, your body started having hyperglycemia till morning. In that scenario, the treatment is going to be to reduce the dose of रात वाला या डिनर वाला जो अपना इंसुलिन होता है वो. So that is how you manage these women, these patients. I will come back to it again कि इंसुलिन कौन सा स्टार्ट करना है वो सब मैं बाद में फिर से बताऊंगा. But this is how you basically manage these patients. The moment she tells you, coming back to the history, that how are you diagnosed, she tells you that at 15 weeks of gestation I was diagnosed of it, you can indirectly just determine कि शायद this was the reason for her diabetes, or this was a test that was done. We have spoken about DIPSI. It is the first trimester screening. I'll be coming to OGDT in a while. Before that, I would want to tell you what are the other specific things that you would ask in the history. You have asked about two things. Ki when was it diagnosed? So the first question was, when was it diagnosed? How was it diagnosed? And now, what are you taking for it? So insulin ले रहे हो या OHs ले रहे हो metformin या फिर MNT पे हो. So you would ask this. Then you would ask them if you're doing self monitoring of blood glucose. You will ask them if you have maintained any blood charting, कुछ maintain किया है क्या. वो हाँ बोलेंगे या ना बोलेंगे. If it is no, then you preferably admit them and do that monitoring. SMBG is self monitoring of blood glucose. But you would ask them all these questions and how they are measuring or how they are monitoring. Apart from that, you will ask them if they have had any specific complaints. Complaints any if they have had burning micturition, basically an increased risk of UTI. You would ask them if they have had vaginal discharge, especially candida, recurrent refractory vaginal discharge. All these specific things you are going to be asking them. You are going to ask them if her blood pressure is increased. So 10% is the normal incidence of preeclampsia, but in patients with GDM or over diabetes mellitus it becomes 20%. So it is literally doubling. So does she have preeclampsia? You would ask her about it. You would ask her about the drugs that she is taking. So these are all the specific things that you would be asking her. Now over here, there is one part that you can ask here. There is one, or you can either ask in the obstetric history about all the individual trimesters and if all the tests were done. I would want to ask it later on. Until here, we are fine. You would ask her about her past medical and surgical history if she gives you any history of something like hypertension or earlier diabetes mellitus in her first pregnancy, or you will ask her about her thyroid disorders, tuberculosis, asthma, or epilepsy. All these factors you would be asking her about it. Apart from that, you would be asking her if there is any history of any surgical illness, any previous surgeries that she has had. The most common ones are cholecystectomy, appendectomy, and obviously cesarean section. Family history, you would be asking her if a family has parents who have diabetes mellitus. Drug history, obviously you would be asking her what all is she consuming. Is she consuming, सबसे importantly, aspirin, because it was diagnosed in the first trimester. If she is consuming aspirin, what is the dose of aspirin that she is taking? Low dose aspirin is anywhere between 60 to 150 milligram. Why do we give low dose aspirin? That is a topic that I shall be discussing in preeclampsia. Aspirin ले रही है क्या, folic acid ले रही है क्या, calcium, iron, and सबसे important metformin or insulin. Also, if she is taking any antihypertensive agents, if she has preeclampsia. So these are all the important things that you would be asking her कि क्या क्या ले रहे हो. Now coming to insulin, when she mentions that she is taking insulin, first of all, what is the status of OHS during pregnancy? Is it safe? Yes, it is definitely safe. It has been determined that it is safe. There are two drugs that have been said to be safe, metformin and glyburide. उसमें से glyburide is something that we don't usually use. We use metformin. The maximum dose per day is 2 gram per day. Insulin, what are the different types of insulin we know of? Ultra short, short, intermediate and long acting. इसमें से ये दो जो है वो हम प्रेगनेंसी में यूज़ करते हैं. लॉन्ग एक्टिंग उसका डेटा अब तक श्योर नहीं था, बट नाउ डेज वी आर स्टार्टिंग टू यूज इट मोर. दे वर सेइंग दैट लॉन्ग एक्टिंग लाइक डेटामेर एंड ग्लार्जिन वर लीडिंग टू मैक्रोसोमिया, but now there is more data that is coming up and that is saying that you can use it. Ultra short is kind of pointless. It just serves एक brief period के लिए sugar levels control करना, so we don't use it. So what are the two major types of insulin that we use? The first one is going to be regular insulin and the other one is going to be NPH, that is neutral protamine hagedon. That is what we use generally. If they ask you the doses, which they won't really ask you, then you have to give 2/3 of the dose in the morning and 1/3 at night. It has to be 50% of NPH, 50% of regular insulin. You don't need to know it at this point of time. Fine. Now coming to the next point of this discussion. We'll be asking her about her obstetric history, her previous pregnancy. We have just mentioned that she is a previous LSAS. So I will ask her in the previous LSES? Was it a male or a female? Secondly, what was the fetal weight if it was macrosomic? Most important, what was the indication? Non-progress, failure of induction, all these things are very classically seen in women with diabetes mellitus. Non-progress of labor is something that baby इतना बड़ा था कि नीचे नहीं आ रहा था. Failure of induction, why was the induction done? She mentioned that I had PPROM back then. So yes, you have to ask if she had any comorbidities, did she have diabetes in that pregnancy as well? If she did have, then what was the drug that she was on? Does she remember it was an injection or it was an oral drug? Apart from that, did the baby have an NICU stay? Often women with extremely uncontrolled diabetes will have babies that go to the NICU. A short discussion on the babies. What does it do to the baby? We have mentioned that it is polycythemia. So imagine the baby doesn't die, it is delivered. Now the problem is that polycythemia to hai usme. I understand that polycythemia though at some point those fetal RBCs are going to die. So it leads to hemolysis at some point. It is an ongoing process. Hemolysis is an ongoing process. When it was inside the mother's womb, the placenta was doing the work of conjugation of that unconjugated bilirubin. But once it is delivered, at this point, what happens is there is no placenta, and the fetal liver is too immature to conjugate such large amounts of unconjugated bilirubin. This leads to an increase in unconjugated or indirect bilirubin in the fetus. Unconjugated bilirubin is not soluble in water, it is not excreted through the urine, and it enters the brain. It crosses the blood-brain barrier. It goes and deposits in the basal ganglia, and that leads to Kernicterus. Kernicterus can lead to cerebral palsy and even fetal neonatal demise. Apart from these things, there is one more thing that has happened. The fetus now is used to extremely high amounts of blood glucose levels that are coming from the mother. So it has in itself increased the beta cells in its pancreas. These beta cells are producing large amounts of insulin. But once the fetus is delivered, the maternal glucose is cut off, the cord is cut off, but the insulin levels are still high. This imbalance leads to hypoglycemia in the fetus, because insulin exceeds the amount of glucose that is coming in, especially for a female who is unable to lactate for the first day or two. This baby is not getting enough of glucose from its mother either. So this leads to hypoglycemia. This hypoglycemia can lead to neonatal seizures, and this can lead to HIE and neonatal death. Apart from that, remember that this fetus had excessive amounts of beta cells, increased insulin. This increased insulin meant increased insulin like growth factor. This led to macrosomia. It also led to the deposition of a lot of fat on its shoulder, which leads to shoulder dystocia during labor. This macrosomia, this hypothesis that I just explained is Pedersen's hypothesis. This hyperinsulinemia wala, it is a Pedersen's hypothesis. But it is not just acting on the body's weight, it is also acting on several other tissues, which includes myocytes, myocardium. Myocardium, there is going to be a proliferation which will lead to hypertrophic obstructive cardiomyopathy. The ventricles are going to be enlarged, the ventricular septum, interventricular septum is going to be enlarged. This leads to HOCM. But the good part is that this HOCM can be reversed once it is delivered, because it was dependent on those high insulin levels. So once the mother's glucose supply is cut off, the fetal insulin will gradually recede and these findings will change. Unfortunately though, there are other aspects to it that won't change. What are those? The other anomalies that this fetus incurs. Now what is the problem with anomalies? Now the problem with anomalies is that glucose leads to increase in free radicals. Glucose in itself is a very toxic molecule. These free radicals lead to DNA damage in the embryo. Embryo matlab पहले trimester में DNA damage in embryo. This leads to genetic mutations. These genetic mutations can lead to two things. What are those two things? Either there can be chromosomal aneuploidies, or they can lead to just gene mutations. क्रोमोसोमल एन्यूप्लॉइडीज आर इन अ वे अ गुड थिंग टू हैपन बिकॉज क्रोमोसोमल एन्यूप्लॉइडी अगर हो रहा है तो उससे रिकरेंट प्रेगनेंसी लॉस होगा. नॉट दैट ग्रेट अ थिंग बट एटलीस्ट देर इज नॉट अ पुअरली फॉर्म्ड बेबी दैट इज बिन डिलीवर्ड. सो क्रोमोसोमल एन्यूप्लॉइडीज से रिकरेंट प्रेगनेंसी लॉस होगा या फिर उससे ट्राइजोमी 21 जैसी चीज़ें होंगी. डाउन सिंड्रोम होगा. डाउन सिंड्रोम थैंकफुली कैन बी डायग्नोस्ड ऑन अल्ट्रासाउंड. सो इट्स a relatively good thing to happen. The worst part is if there are genetic mutations that lead to congenital anomalies. Now, these anomalies will not kill the fetus, it will not lead to abortion. This baby will be carried till term. And the most important ones are neural tube defects. Sacral agenesis is the most common, or caudal regression syndrome is the most common. And बहुत ही important है cardiac defects. Cardiac defect में most specific is TGA, that is transposition of great arteries. Most common is VSD. There are others as well that can occur. HOCM जैसी चीज़ें, बहुत सारी चीज़ें हो सकती है, but these are the two commonest anomalies that can happen. How do I know कि हो रहा है कि नहीं? It depends on the HbA1c levels. So remember, all these things are occurring in the first trimester. So remember that these mutations, these congenital abnormalities can only occur in overt diabetes mellitus and not in gestational diabetes mellitus. Gestational diabetes mellitus में macrosomia होगा. Macrosomia होगा because baby का growth तो continuous है, but anomalies and aneuploidies नहीं होंगे. So remember that your GDM patient is not going to have all these problems. Only overt diabetes mellitus patients are going to have this problem. How do you determine the risk? It is by HbA1c. The higher the HbA1c levels, the more the risk of this developing. Talking about overt diabetes mellitus, what are the 3 tests that I can do? FBS, either one of them has to be positive. RBS or HbA1c. How do I diagnose overt diabetes mellitus on the basis of this? Fasting has to be more than 126, or RBS has to be more than 200, or HbA1c has to be more than 6.5%. So any of these, if it is positive, then the female is known to have or is going to have overt diabetes mellitus. So coming back to this, these are the problems that the baby can face. So you would ask this about a first pregnancy. Now is a current pregnancy, present pregnancy. What all am I gonna ask her? So each trimester has its own specific things. In first trimester it was diagnosed. So what are the things I will ask her about? I will ask her, once it was diagnosed, did you do any fetal scans or any surveillance things? She says yes, I had done an NT-NB scan. NT-NB scan is nuchal translucency and nasal bone. It is done between 11 to 14 weeks of gestation. If you want it to be a little more specific, then you can say that it is done when the crown rump length is between 45 to 84 millimeters. So it is done between 11 to 14 weeks of gestation. NT stands for nuchal translucency. So if this is your fetus, it's a very poor diagram. If this is your head, if these are your hands, if these are your legs. Nuchal translucency, if these are your eyes, nose and mouth. So nuchal translucency is basically the translucency of this area. Now it is something like edema. A very easy way to understand is it is like edema. It is a dependent part of that fetus, and अगर यहाँ पे edema जम रहा है, it shows that there is something that is leading to edema. Now how does edema occur in an adult, or why does it occur? If the patient has any cardiac anomaly or cardiac problem which is leading to heart failure and congestive heart failure leading to edema, or if the patient or baby has, or the adult has renal dysfunction, or if the patient has liver dysfunction. So at 11 to 14 weeks of gestation, if there is an aneuploidy, then this fetus might have some cardiac abnormality. That cardiac abnormality is leading to this increased translucency more than 3 mm. So if the nuchal translucency is more than that, it is taken in the mid sagittal section. If it is more than that, then the screening is to be positive. This is a screening test. If screening is positive, then I need to do a definitive test for gold standard diagnosis, and that is going to be either chorionic villus sampling or amniocentesis for karyotyping. The other test that I do is dual marker. If the female has registered late with me, then I do a quadruple marker. I do not do both of them. It is only done if one has been missed. Dual marker में 2 आता है, plasma associated pregnancy associated plasma protein A and beta HCG. So B, A and B is the dual marker. Whereas quadruple में आता है alpha fetoprotein, beta HCG Unconjugated estriol, there is a technique that I had mentioned yesterday on how to remember that is this is estriol and not estradiol. A female's life, a female's life has three phases in her life. The first is the period that she spends in the pre-pubertal and post-menopausal age. So basically she spends around 50 years of her life in this phase. So maximum time is spent यहाँ पे, तो estrone that is E1 is present in this phase. The next is her reproductive years. Reproductive years are between 13 to 45, so around 32 years. Second highest, that is estradiol. So estradiol is a predominant hormone in her reproductive years. वैसे estrone was in the postmenopausal and prepubertal years. And the least time that she spends is during pregnancy. Pregnancy में 9 months if one pregnancy, 18 months if two pregnancy, not more than that. At that time she has estriol, that is E3. So pregnancy में unconjugated estriol. And lastly, inhibin A. How do you remember inhibin A? The first thing that comes in your body is going to be A. उसके बाद में आगे की ज़िंदगी में inhibin B आएगा जो ovaries रिलीज करते हैं to inhibit FSH. So first thing in your life that you learn is ABCD, और उसमें से A सबसे पहला alphabet है, hence A. So these are all the quadruple markers. There is also something called as non-invasive prenatal testing that you can do, which is also a screening test. ये सब screening test है. इसमें से कुछ भी पॉजिटिव आता है, इट डज नॉट गिव यू अ डेफिनेटिव डायग्नोसिस. इट ओनली टेल्स यू दैट यू हैव टू गो अहेड एंड डू अ डेफिनेटिव डायग्नोसिस बाय एमनियोसेंटेसिस ऑफ कोरियोनिक विलस सैम्पलिंग. सो फर्स्ट ट्राइमेस्टर में ये सब किया था कि नहीं पूछना है. सेकेंड ट्राइमेस्टर में सबसे इंपॉर्टेंट चीज़ आएगा मेरा सबसे पहले तो डिप्सी, इफ इट इज़ नॉट डन इन द फर्स्ट विजिट. सेकेंडली टिफा, दैट इज टारगेटेड इमेजिंग फॉर फीटल एनोमलीज, एंड 2D echo of the fetus. This is done between 22 to 24 weeks when all the four chambers of the heart are visible. The three most important things that are done. Also towards the late second trimester we also do OGTT. Now coming to OGTT, अभी तुम्हारे बुक में there are multiple things that are given. आपको सिर्फ IADP-SG का याद रखना है, International Association of Diabetes Study Group in Pregnancy. So OGTT in India is done with 75 gram glucose. Now remember how to remember, India में डिप्सी भी 75 है और OGTT भी 75 है. US में OGCT जो लोग वो बोलते हैं is 50 gram which is a screening test, and OGTT which is again the definitive test is 100. So same way 150 इनका टोटल है. वैसे इंडिया में डिप्सी का 75 and OGTT का भी 75. अगेन द टोटल इज़ 150. एन ईजी वे टू रिमेंबर, इंडियंस ने ईजी कर रखा है खुद का काम, 75 दिया है. इसमें यू टेस्ट द फास्टिंग ब्लड ग्लूकोज, you check the first hour ka sample and you check the second hour ka sample. If any one is positive, then you say that the female has diabetes. So the fasting levels have to be less than 92, 1 hour levels have to be less than 180, and 2 hour levels have to be less than 153. US के OGTT में there are O Sullivan, Carpenter Couston, NDG, ये सब वैल्यूज़ है. यू डोंट रियली नीड टू रिमेंबर देम, दे आर पॉइंटलेस, क्योंकि इंडिया में वो प्रैक्टिस नहीं होता है. प्लस दोज वैल्यूज़ ऑफ 100 ग्राम. इंडिया में सिर्फ जो प्रैक्टिस होता है वो IADP-SG है, उतना ही करो काफ़ी है. दीज आर द 3 वैल्यूज दैट यू नीड टू रिमेंबर. और कुछ याद मत रखो, इंडिया का भी याद रख लिया तो काफ़ी है एग्जाम के लिए. इसमें से अगर एक भी वैल्यू पॉजिटिव आई देन शी इज़ नोन टू हैव GDM. इफ एनी ऑफ द वैल्यूज इज मोर देन 200 देन शी हैज़ ओवर डायबिटीज मेलाइटिस. वेरी इंपॉर्टेंट एंड सिग्निफिकेंट टेस्ट. थर्ड ट्राइमेस्टर में क्या क्या करोगे? सबसे इंपॉर्टेंट है इंटरवल ग्रोथ स्कैन. सो बेसिकली मैं ग्रोथ मॉनिटरिंग करूँगा कि कितना ग्रोथ हो रहा है, मैक्रोजोमिया हो रहा है कि नहीं. इफ़ द फीमेल हैज़ एनी वैस्कुलोपैथी, हाउ डू आई स्कैन फॉर वैस्कुलोपैथी? रेटाइनोपैथी है कि नहीं देखने के लिए मदर का मैं फंडोस्कोपी करूँगा. आई कैन डू दिस इवन इन द सेकेंड एंड फर्स्ट ट्राइमेस्टर. इफ़ शी हैज़ नेफ्रोपैथी, वो देखने के लिए मैं करूँगा renal function test which contains BUN and creatinine. These are the 2 important tests that I do. I can also do a kidney urine bladder, a urinary bladder scan, a USG. तो इंटरवल स्कैन देखना है, इंटरवल ग्रोथ मॉनिटरिंग करना है. इफ़ द वैल्यू इज इंक्रीजिंग मोर देन 97 सेंटाइल देन इट इज़ मैक्रोजोमिया. इफ इट इज़ नॉट इंक्रीजिंग तो नॉर्मल है, कुछ करना नहीं है. वंस इट क्रॉसेस 97 सेंटाइल देन आई नीड टू कंसिडर अ डायरेक्ट LSCS फॉर हर. अदरवाइज इन इंडियन सिनेरियो informally we consider more than 3.5 kg as macrosomia, but globally the accepted number is more than 4 kg. So you can answer this because Indian women are short in stature than Caucasians. Their pelvises are smaller. Caucasians are all the Western people. they are short in stature, they are diminutive, and smaller pelvises 3.5 kg तक डिलीवर कर देते हैं. उसके ऊपर शोल्डर डिस्टोशिया, ऑब्स्ट्रक्टेड लेबर, ये सब के चांसेस बढ़ते हैं. हेंस वी डोंट गो फॉर अ वजाइनल डिलीवरी. फाइनली ये सब बेसिक हिस्ट्री पूछना है. ड्रग्स कौन से ले रहे हो, मॉनिटरिंग किया है कि नहीं पूछना है आपको, फीटल 2D को किया है कि नहीं, एंड that is it about the obstetric history. You come to the examination part. In examination, you first check for her general condition, which is going to be fair enough. If she is febrile or not. Febrile का significance ये है कि chorioamnionitis का risk is increased in these women. So high grade temperature should make you think of preterm premature rupture of membranes. You have to do a per speculum examination. You have to collect a swab to know whether there is any possibility of chorioamnionitis. CRP करना है, WBC counts देखना है, pulse देखना है, BP देखना है associated with preeclampsia, CVS system RS देखना है. Most importantly, per abdominal examination. Per abdominal examination में there are Leopold's maneuvers that you have to check. उसमें सबसे important is going to be symphysiofundal height. In cases of macrosomia, it is going to be more than gestational age. So symphysiofundal height देखना है. Then you have to check Leopold's grip से whether the head is engaged or not. If it is macrosomic, then the engagement of head will not occur and the head will be stuck up ऊपर. Per speculum examination, which you don't have to do, but if you're asked कि क्या देखोगे, you will say you will look for white discharge है या नहीं. And if the female is giving history of leaking per vaginum, then you will confirm कि amniotic fluid वहाँ पे है या नहीं. How do you terminate them? We terminate them if the baby is crossing the macrosomic age, then by LSES or by induction of labor at 40 weeks for, मैंने जैसे बताया, medical nutrition therapy, 39 weeks for insulin pay women and 39 weeks for metformin women, and 38 for women who are on insulin. What are the precautions that you take in labor? You skip the morning dose of insulin or metformin. Intra labor, you do 2 hourly sugar monitoring to check if she is having any problem, if she is having hypoglycemia or hyperglycemia. If it is occurring that it is hyperglycemic or if she is going above 120, then you start the female on sliding scale. You don't need to remember the values at your point. स्लाइडिंग स्केल में हम लोग उसको इंसुलिन का एक ड्रिप लगाते हैं इन नॉर्मल सलाइन टू एंश्योर दैट शुगर लेवल्स आर मेंटेन्ड बिटवीन 90 and 120. Apart from that, if it is a cesarean section, an elective cesarean section, then this patient should be the first patient that you take for cesarean section in the morning. Post-operatively, there is an increased possibility of this female having wound site infection, that is surgical site infection or puerperal sepsis. So you have to give them adequate cover of antibiotics. You have to keep their wound clean. You have to keep it dry, and you have to ensure that the female is lactating well, क्योंकि mastitis की risk बढ़ती है. The fetus might need the neonate, the baby has to be kept in the NICU for its own sugar monitoring so that उसका खुद का sugars कम ना हो. So for a day or two it is kept in the NICU, and all these things, once you are done, you have ensured that you have delivered the female successfully and you have managed this female well with diabetes in pregnancy. I don't believe there is anything more that has to be discussed. If there is anything left out, you all can message me, you all can ask me. If you all have any doubts, definitely. I am not going to be teaching the dietary history part. I really don't. I find it very drab. You all can read it from the books. Apart from that, that's it from today's session. We shall have next session very soon. I shall keep you all informed. Until then, keep watching me and we shall have many more such videos. Thank you.